Once again, thank you very much. I would like to thank the organization of AASD and MSD for allowing me to give this lecture in this conference. I'm going to speak about management of newly diagnosed type 2 diabetes. What after metformin? What do we do after metformin? First of all, I will start with the IDF latest edition. Worldwide, diabetes is a big problem and it is increasing. It has increased from 463 million to become 700 million in 2040. That means a 51% increase. In Africa, it will increase from 19 million to 47 million, and this will make 143% increase. Also, in the Middle East and North Africa, it will increase from 22 million to 108 million, a 96% increase. Another very interesting issue is that not all people with diabetes have kidney disease or cardiovascular disease. The majority don't have it. So we say that in 63 or 65%, there is no cardiovascular disease and there is no chronic kidney disease. This is very good. We say that the mix between cardiovascular and chronic kidney disease is 8.6. And we also say that a chronic cardiovascular, I mean cardiovascular disease alone, is about 13%, and the chronic kidney disease is around 15%. And that is if the patient does not take treatment, but if he takes regular treatment, it will be less than this. So we must focus on diabetes. What do you mean by focus on diabetes? I mean the following. I mean, take care of glycemic control. So we say that the standards of medical treatment in diabetes since 2018, 2019, 2020 always said that A1C is an important thing, and they stressed that the A1C usually around or less than 7 unless in certain conditions. They also said that please, the pre-prandial, which is the fasting, should be from 80 or the capillary less than 180 milligrams. So there must be a balance between strict control and less strict control. If I say strict control, I must be sure that the patient doesn't have hypoglycemia. It's simple. He takes simple medications. The lifestyle, he's usually on lifestyle or metformin only. There's a short duration of the disease, and he has no cardiovascular disease and a long life expectancy. If I say less stringent control, well, in this case, he has limited life expectancy. He gets attacks of severe hypoglycemia, and the therapy is very difficult to control, and he has cardiovascular disease. So what is really annoying, if you look at this diagram, only 52% reached goal in the United States. And this is the highest incident of hemoglobin A1C. All the rest, the countries are from 26, 23, 33%, all of them. That means that seldomly we reach goal with the treatment of diabetes as regards hemoglobin A1C. Another very, very strange thing is that we don't intensify the treatment for many years. So we see that most alarming was the finding that even among patients in the highest index of hemoglobin A1C category, which is more than 9%, therapy was not intensified in 44% of the patients. We should not delay the treatment at all, because I am afraid of myocardial infarction, stroke, heart failure, and other diseases. Myocardial infarction occurs in 67% of the patients. Strokes occur in 51% of the patients. Heart failure If I don't intensify the treatment, it will occur in 64%, and the cardiovascular events in 60. So I must intensify and take care of the patient. Never leave him on one or two medications for a long time, claiming that I will preserve his pancreas. This is terrible. Why? What we should consider after a metformin in type 2 diabetes? Well, first of all, there is no one size that will fit all. I must individualize each category should take its own treatment. Each one, he should be tailored with his treatment. The glycemic efficacy, the hypoglycemic risk, what about his weight? What are the other benefits? Does he have comorbidities? I must put all these things into consideration. And when I make a combination, I should make a combination from the drugs that are synergic to each other, that will help each other in its work, not opposite to each other. So if I say metformin, yes, it will increase insulin sensitivity and it will work on both the muscles and it will decrease the glucose production. And of course, DPP4, it will decrease the glucose production, increase insulin secretion, and these together will be optimal. Other drugs are present, but these two will be optimal to be added together. Okay, if I look at the recent consensus statement or guidelines, okay, I'll find that cardiovascular risk and chronic kidney disease, and this is not the case that we are working on. We're working on the early patients who don't have it. But in spite of this, we find that DPP4 can be added to any category. It can be added to those with cardiovascular risk, those with heart failure, those who want to minimize hypoglycemia, those who don't want their weight to be increased, and also those who have a major cost issue. I can add a DPP4 as a generic or a low-cost budget. Okay. Also, if you look at most of the recent guidelines, we'll find that choosing glucose-lowering medications, I need the following. If the patient wants to minimize his hypoglycemia, and at the same time, he doesn't have any cardiovascular risk, first-line therapy is metformin, okay? If the hemoglobin A1C is above target, above 1.5 to 2%, then I should add a second drug. What drugs? All drugs are available. DPP4 are very good. GLP-1s are very good. Those that act on the kidney are very good, but please take care of the prostate if he's a male, and please take care that he doesn't have a urinary tract infection or the lady doesn't have UTI infections. And TZDs, and each drug of these drugs, or each one of these drugs, as we know, we should individualize. I can't put in heart failure TZDs, but if I put DPP4 and the patient inhibitor does not reach goal, then I can add either a TZD or SGLT2. If not, then I can add sulfonylureas or other drugs or insulin. But please, DPP4 are never added to GLP-1. I don't block the whole road, and then a small side road I should block it. العربية وهي ماشية في شارع واحد. لو أنا قفلت الأصل بتاعه التفريعات اتقفلت. So I don't give DPP4 inhibitors with GLP-1. Okay? Now, if I put these two drugs together, I'll find that metformin and sitagliptin augment their work together. They improve the beta cell function, decrease hepatic glucose production by various means. Metformins, there are insulin sensitizing drugs on the liver and on the muscles, and also they decrease the hepatic glucose output. So, if I could compare the dual therapy, which is sitagliptin together with metformin, and I compare it with metformin alone, it will be more superior. So, Genomet, when it is given in comparison with metformin, if the hemoglobin A1C is very high, there will be a 3.6 reduction in the very high levels. Also, this combination and another combination, which is glimepiride, it is not inferior to glimepiride with metformin. Same results. And at the same time, it has a maintained efficacy. That means that if I use other drugs or other competitors with metformin, after 30 months, I will have a problem, which is the blood sugar will be elevated, but with the DPP4 combination with sulfonylurea, it will not. It will give us a maintained level in compared with sulfonylurea metformin or TZD's metformin. So the hemoglobin A1C will not rise again for at least 60 months. Also, those patients who are on Janomet or sitagliptin and sulfonylurea, together they have a 24% less reduction in initiating insulin. So 24% lower early introduction of insulin in this group. And also their initiation to insulin will be decreased. Also, the safety studies, the TICO study said it does not, the DPP4 sitagliptin, cause increase in the cardiovascular risk. And at the same time, it does not cause heart failure or hospitalization for patients with heart failure. And this is in contrast with other studies like the EXAMINE and the SAVR. The EXAMINE study said that there is a high risk of heart failure with allogliptin, and the SAVR significantly, the heart failure is increased with saxagliptin compared to placebo. Okay, so it is a relatively safe drug, and if we take the pooled analysis from 1,400 patients from 25 randomized control studies, I will find the following. It has similar rates with the other placebo or competitors, including the major side effects: no bone fractures, no infections, no angioedemas, and no malignancies. The incidence of malignancy will be the same as the placebo or the other drugs that were used in the other studies. So my take-home message is glycemic control is very important in the management of diabetes. Secondly, please individualize your therapy for each patient. Not every patient will take the same drug. Please, I don't want to see a patient after 5 years on one drug with the A1C 15. This is terrible, and this is what we see now. I should, every 3 months, re-evaluate. I should add other drugs, and I should intensify my medications every 3 months so that no complications happen. The decision should be based on evidence, guidelines, and your medical expertise as it was discussed. And it is very important that I ask the patient how much can he benefit from this drug, and I ask him what is his income before I write a drug. But as a whole, the DPP4s are relatively, as price-wise, very logic and good for most of our patients, in contrast with other drugs that are extremely expensive. And again, it is a very good drug to be taken. You can start with it, or you can put it as an extra drug, but please, not with the GLP-1 antagonists, please. Not in type 1 diabetes to the present time, because it must work in the presence of insulin. For type 1, they don't have insulins. And please, before writing it, individualize your medications, and every 3 months, re-evaluate so that cardiovascular risk does not occur. And we all say that from 65% of our patients do not have cardiovascular risk. If you enter into the region of the 63 to 65%, you are very safe. But at the same time, if there is a risk of cardiovascular disease, then my strategy will change a little. And thank you very much.